Thank you. So, as most of you are aware, PRRT is widely practiced in an empiric fashion, where the standardized, what is standardized is actually the injected activity. For example, one of the most popular protocol is 7.4 gigabecquerels of lutate for 4 initial or induction cycles, including in the NETTER-1 trial. However, we must acknowledge that a one-size-fits-all protocol is convenient. But then it's also known that it yields random doses to critical organs, including the kidney, which is the dose-limiting organ in most patients. And this is because of highly variable kinetics across patients. But the renal doses are rarely above the conservative threshold of 23 grays, and probably this explains, at least partly, why lutate PRRT is not very toxic. But in the end, this yields sub-maximal tumor doses, meaning under treatment of most patients. One solution to solve this issue would be to increase dose fixed activity, so to do a dose escalation study where all the patients would receive more and more injected activity. But that would invariably result in progressively increasing severe toxicity rates. The alternative approach is to personalize PRRT. And so personalized PRRT is about standardizing doses, and to start with the critical organ, the kidney, so to standardize the renal dose and the dose rate. So here I mean by dose rate the average dose per cycle, to limit the risk of renal toxicity, of toxicity in general, including also hematological toxicity. To achieve this, we must personalize the injected activity to deliver the prescribed renal dose. And this would result in sorry, my shade of blue is a bit dark, but a maximized tumor dose with the goal to increase the likelihood of response. So our aim was to assess the potential of personalized PRRT to safely increase the absorbed dose rate to tumors. And we did that by simulating a personalized PRRT protocol, a P-PRRT, I call it, in a retrospective cohort. This cohort consisted of 22 net patients who received 4 cycles of lutetium octreotate with an empiric injected activity, and that was because they were receiving it under the special access program of Health Canada, and there's no room for experimenting under this program. So they received more or less 7.4 gigabecquerel per cycle, but they all underwent quantitative SPECT-CT-based dosimetry after every cycle. So in brief, the way we perform dosimetry with QSPECT, so each patient undergo serial QSPECT-CT studies, one at approximately 4 hours after the administration, so after the amino acids, basically, one the next day at 24 hours, more or less, and one on the 3rd day. Then we draw spherical volumes of interest of 2 centimeters over tissues of interest to sample the average activity, and then we plot the SUV values, which is defines the biological time activity curve. To this, we add the physical decay, integrate, multiply by those factors to obtain the radiation dose to those tissues. For the bone marrow dosimetry, we assess the self-dose in the same fashion as we just described, but we add a cross-dose component based on whole body retention. And that can be particularly significant in those patients with a very high tumor burden and very high uptake and retention in the tumor. So for the simulation, the prescribed renal dose was the 23 gray over 4 cycles, which we know it is conservative, but it's not reached in the majority of patients. We divided that so that the prescribed dose at the first cycle was 5 gray, and on average, it would be 6 gray at each of the following cycles. Although we did split for the following cycles, the remainder of the activity that was not delivered at the first cycle among those cycles, and we did that iteratively at each cycle. There was a dose reduction in cases of impaired renal or bone marrow function, and this was 25% less in case of grade 2 or 50% less in cases of grade 3 impairment. And that, I reckon, was empiric, but we need to start somewhere. And also, we limited the increase of injected activity at any cycle to 50% above the highest injected activity ever received by the patient, and we decreased that in cases of grade 2 or 3 subacute toxicity. And that was basically to be, for me and my colleagues, to be clinically comfortable to administer those treatment in the future. Because sometimes the calculation at the first cycle tells you should inject 30 or 40 grays, not grays, but gigabex at the next cycle. So by limiting to 50%, it was like quite rapid, but dose escalation in each individual patients. So for the cycle 1, we observed that the renal absorbed dose to the kidney per unit of injected activity normalized for the body surface area in square meters, correlated moderately well with the renal function expressed in terms of eGFR. So we use the linear regression of this relationship to calculate the personalized injected activity to deliver at the first cycle with these equations. For the next cycles, then it was simpler because we already observed that the mean cycle-to-cycle renal dose difference is very little. In fact, it's very reproducible between cycles within 10% of standard deviation, so within 20% for the vast majority of patients. So we use the post-cycle dosimetry to predict the renal dose at the next cycle and calculate the injected activity to administer based on this. So here are the results. As you can see, the simulation results show that we could have increased the injected activity by almost 50% between the empiric and the personalized protocol. And as you can see, whereas in the empiric regime, there was very little variation between the dose, obviously. Then there's a very wide variation between doses the patient receive under the personalized treatment. And the same applies to the cumulative injected activity. But most importantly, the kidney dose was the patient actually received on average 16 grays with quite a significant inter-patient variability, whereas under the personalized protocol, they would have received almost on average 23 gray with a very little variation, but as the rules we've set, some patients would receive or would be prescribed less than 23 gray, explaining the variability, and not that much we were quite accurate to deliver the dose, the prescribed dose over 4 cycles, despite the variability of the prediction at the first cycle. But the most important thing maybe is that we could have significantly increased the tumor dose by, again, almost 50% on average, and in certain patients by more than twofold, again, without exceeding the very conservative 23 gray. So this is something I think significant. And all those results, of course, were statistically significant. So standardizing renal dose rate, the personalized PRRT is about standardizing renal dose rate over 4 cycles by personalizing injected activity at each cycle and maximizing, sorry again for the dark blue, maximizing the tumor dose and the potential benefits of PRRT. It's feasible. I've not done a cost analysis, but doing 2 more SPECT CTs and spending a little bit of time when you're used to, it's not that long to calculate the dosimetry. It's not that much cost and resources compared to the cost of the molecule itself. And considering the established strong prognostic value of response to PRRT, I would conclude by saying that each individual NET patient deserves the best chances to respond to PRRT. So I'm thankful to the funding institution, Fonds de recherche en santé du Québec and Canadian Institute of Health Research, my nuclear therapist colleagues, as well as Sud Québec dedicated nursing and NM staff. Thank you for your attention.
Thank you very much for a very nice presentation. Are there any questions? Please, if you can go to the microphone.
Hi, John Strasberg from Moffitt Cancer Center in Tampa. Great talk. Both your talk and the previous one focused on the maximal tolerated dose in the kidney. Yet we saw in the NETTER-1 study and other studies that the kidney nowadays doesn't seem to be the dose-limiting organ as far as PRRT. If anything, I would be more concerned about the bone marrow. Is there any risk that by maximizing dose to a certain renal threshold that you might be inducing more toxicities outside of the kidney?
We'll see. I reckon that the data is conflicting between the bone marrow or whether it's the bone marrow and the kidney that is the critical organ in most situations. Our experience it's that the kidney, it is the kidney also, I think that from the Uppsala group, but maybe from your study, the NETTER and the Rotterdam group, I think it's more like they define the bone marrow as the most often the critical organ. But it's hard to tell because we know that it's not the gray of PRRT is not the same gray, it's the same energy deposited, but not in the same fashion as external beam radiotherapy. So we know those values are still very conservative, and the toxicity rates in clinical practice are so low that we cannot establish at the moment any reliable dose toxicity relationship. And I mean, of course, for platelet, we can see the mild platelet drops, and we're not concerned about that, but for developing MDS, leukemia, or end-stage renal failure. So if we don't try, I think most other treatments are way more toxic than PRRT, and I don't see any reason that PRRT, because it's radiation or something, must be non-toxic, otherwise it would be scary. So we need to test it, to increase the doses and injected activity.
Great, thank you.
Thank you. I think we're running out of time, but without wanting to put a bullseye on my back, do you really think that every patient needs this level of personalized dosimetry? Looking back, especially in a healthcare system like in the US, at the use of Levelin and Bexar, if it was a choice, most practitioners have gone for the easier one to administer for Zevalin, and between the two, the results were pretty similar. So is it not on us to identify who really needs this kind of detailed dosimetry, or?
But, well, first we need to try if it's worth it. In my mind, there's no doubt that more radiation to the tumor cannot be detrimental unless it gives excessive toxicity, but to the tumor itself, it can only be beneficial. So yeah, time will tell if our approach is valid or not.
Just a comment, I think that as a field, it would be probably useful to actually determine what the maximum tolerated dose of the kidneys is. I mean, we're probably underdosing rather systematically, so it might be useful to do some studies, especially in higher risk patients, where the dose to the kidneys is escalated. Similarly, if you want to know if personalized dosimetry is better than, sort of like a fixed dose, it seems like that does lend itself to a study. So I think we probably could answer some of these arguments if we could figure out a way to assemble these questions and look at it in a multidisciplinary collaborative fashion. I think it really is a little open to discussion. But thank you much for your excellent talk.
Thank you.
Thank you.